I have the pleasure to invite the first speaker, Dr. Carrington. He's going to share with us pressure points in primary care, a study of blood pressure in 532,000 patients, primary care patients. Thank you, Dr. Carrington.
Thank you, chairpersons, and good afternoon, everybody. I'd like to gratefully acknowledge the sponsor of this research, Boehringer Ingelheim. As many of you are well aware, hypertension is one of the greatest contributors to preventable forms of cardiovascular disease globally. It's associated with worse morbidity and mortality compared to any other cardiovascular risk factor, and its prevalence remains at historical highs, affecting 1 in 4 adults worldwide. And hypertension rates are projected to increase in the future in accord with an ageing and more obese population. From a population perspective in Australia, we've seen a downward trend in the prevalence of hypertension before showing a rebound upwards, with the latest snapshot of blood pressure levels being derived from this national study, which we conducted in 2007, involving just under 14,000 patients. And the results can be found here in this IJC manuscript. But within this study, we collected blood pressure measurements on one day in 100 shopping centre locations across every state and territory in Australia, and we used a field force of over 300 registered nurses to capture these data. And results showed that this was one of the largest surveillance studies to ever be undertaken in Australia to date, with results showing high levels of elevated blood pressure, with 28% having high systolic values, 16% having high diastolic values, and overall about 1 in 3 of the people screened had a blood pressure above the historical target of 140 on 90. And we also showed key differences in blood pressure, with men having higher values than women, people from regional locations having higher values than their metropolitan counterparts, and also people from low socioeconomic backgrounds having higher values than people in high socioeconomic backgrounds. From a primary care perspective in Australia, hypertension is the most commonly managed problem. It increased from 8 in every 100 encounters in the late 1990s to 10 in every 100 encounters about 3 years ago. And that's more than double that of lipid disorder management. So hypertension remains to be a key target for cardiovascular disease prevention in Australia, and primary care represents a very important environment to respond to elevations in blood pressure. Therefore, the aim of our Pressure Points report was to describe the pattern of blood pressure and management of hypertension in a primary care environment between 2005 and 2010, and we were really interested in looking at 2 key perspectives. Firstly, assessing broad trends in average blood pressure levels over this period of time, and secondly, to assess the effect of regular physician reviews and active management on blood pressure. In order to do so, we accessed a longitudinal patient database containing information from patients such as their age and sex, clinical information, most importantly being blood pressure values, and prescription information with a key emphasis on cardiovascular disease and diabetes prescriptions. And we excluded data on the following basis during the cleaning process. And we had remaining available data from more than 700,000 patients. We had more than 5 million clinical records, and we had more than 1.5 million prescription records. Overall, more than 500,000 individual patients had at least one blood pressure measurement in the clean data set. And these patients were derived from both metropolitan and regional locations in every state and territory in Australia. And the data were provided by more than 700 primary care physicians from just under 300 clinics. 55% of the patient cohort were women, and there were slightly more women under 34 years of age, as shown by this green shading here, and there were slightly more men between 45 and 74 years of age. So looking at the results, I'll first present the set 1, which looked at the time trends in average blood pressure levels. And these data just utilised patient records of the first blood pressure measurements only, and any subsequent visits that patients may have had over the 6-year period were discarded just for the purposes of this first data analysis. And as you can see, whilst we had statistically significant changes over time, that was really owing to the sheer volume of data that we had, but there were really no clinically significant changes in either systolic pressure or diastolic blood pressure over the study period. Looking at the gender breakdown, whilst overall men had higher blood pressure values than women, there was also no gender effects over time. Overall, 25% of patients had an elevated blood pressure greater than 140 on 90, and when we considered the effect of antihypertensive therapy, or the number of people on antihypertensive therapy, 36% of patients had hypertension. And when we considered antihypertensive treatment, blood pressure was poorly controlled in hypertensive adults, as shown by this blue top line here, with more than 40% of people on antihypertensive therapy having a blood pressure which exceeded the 140 on 90 mark. This slide here shows the individualised blood pressure targets according to our National Heart Foundation guidelines in Australia. And as you can see, there are stricter, lower targets for higher risk patients. And if we were to apply these stricter targets, you would see that there are just under 60% of patients who would not achieve their target, and these are patients who have cardiovascular disease or associated end organ damage. 60% of those would not achieve their individualised target of 130 on 80. And patients on antihypertensive therapy about 50% of those would not achieve the target of 140 on 90, and about 20% of all others not on treatment would also not achieve that target. Looking at the second set of data analyses, which involved blood pressure over contiguous annual visits in patients who had elevated blood pressure. And these analyses utilised patients who had repeat back-to-back measurements, and they could have anywhere between 2 to 6 contiguous visits over the study period. So that's depicted in this diagram here. I know that it's a little bit difficult to see because there's overlapping lines, but this includes patients who have 2 visits, 3 visits, 4, 5 or 6 visits. And as you can see, aside from a benefit after their second annual visit to their GP, there was no ongoing additional benefits with more regular physician review. And just under 50% of patients were not achieving the target of 140 on 90. Looking at a subgroup of people who are placed on antihypertensive therapy throughout that 6-year period, the same trend applies. Aside from an initial improvement in blood pressure levels after their second annual visit to their doctor, there was no additional benefit seen with ongoing physician review or active management, and just around the 50% mark did not achieve the target of 140 on 90. This slide here just shows the types of treatment the patients were on. The main therapies were diuretics, angiotensin receptor blockers and ACE inhibitors, and there was about 50-50%, a 50-50 split of those who were on monotherapy compared to combination therapy. So we then looked at some of the strategies that we have used to bridge that gap and improve blood pressure control in primary care. And one of the strategies that we've recently, or a study that we recently completed, was the Viper BP study. I won't go into too much detail in the interest of time, but the full methods and design paper is published in the RJC. But in brief, the Viper BP study compared the effectiveness of an intensive blood pressure management strategy compared to usual care, whereby patients in the Viper intervention underwent structured follow-up and computer-assisted decisions with clear clinical management pathways. Very briefly, results of Viper showed significantly greater blood pressure control rates in the intervention group compared to usual care. And there was also significantly increased odds of achieving individualised blood pressure control in favour of patients in the intervention arm. We therefore wanted to try and project the impact of these Viper findings into the patients that we have in our primary care cohort. And this slide here just shows some histograms of the systolic blood pressure in patients in our primary care data set with uncontrolled hypertension. And if we were to apply the impact of the Viper intervention, what we would see is a leftward shift of blood pressures to lower values. I'm just going to list through some of the limitations of our pressure points report. The first being that it was a prospective data analysis, and the data were really captured as part of point of care clinical routine management. Standardisation of blood pressure procedures between the GPs cannot be confirmed also, and there was no quality control process. There may have been data entry errors in the data set, which we aim to alleviate in the cleaning process. We excluded over 500,000 records, but some may still have resided in the data. Also, omission of patient data into the clinical software program at the point of care may have occurred. Patients may well have gone to visit their GP, but for some reason, and time's probably the main one, they may not have had their results entered into the software system. GPs were also, all primary care physicians were unblinded to blood pressure measurements and records. The influence of non-pharmacological treatments is also unknown. And patients may have visited more than one GP such that they would be double counted in the data set, and given that we had de-identified data, we were unable to detect this. There's also the potential for white coat hypertension influencing blood pressure values. In conclusion, however, our pressure point study has shown to be Australia's largest study of blood pressure within a primary care environment. Our findings show that blood pressure management remains suboptimal, with no significant change in blood pressure between men and women. There was a lack of achievement of blood pressure targets, which was worsened when we considered individualised higher risk targets. Blood pressure was poorly controlled, and there were no longer term benefits from ongoing annual visits or active management. We showed, though, that a more systematic approach to blood pressure management, and the example being the VIPER study, could be effectively applied to improve blood pressure results. Therefore, early detection and proactive management of hypertension remains to be a public health priority, at least in Australia, and perhaps broader than that. And I'd like to acknowledge my co-investigator Simon Stewart and the big job that it was for a data programmer to link all these data together. Thank you.
This paper is open for questions. Anyone?
Well, excellent work and really impressive numbers. I have one question, and that regards the lack of any added value on continuous visits. And one question is if you want to comment on that, and the second, maybe more importantly, is was there a difference between these follow-up consultations being done by a doctor, were all done by doctors, or did you try to see a difference between being done by a doctor and by a nurse?
Yeah, thank you. So in response to your first question, I think you can see that the values sort of bottom out at around that 140 on 90 mark, and I really think that it's a challenge in primary care and, probably in cardiology, broadly speaking, to get lower targets. There are very strict targets. Some, the proteinuria group's 125 on 75, which may be a bridge too far. But it seems to sort of bottom out around that 140 on 90. So I don't know what the decisions were on the GP as to why they may have stopped. We don't know about doses, whether they were reluctant to up-titrate or similar to that. In relation to your second question, we don't know, and with this particular data set, whether the data were collected by doctors or nurses. I believe it would be doctors, but we don't know. But I'm assuming that the measurements were done by a primary care physician.
If no more questions, we would like to thank Dr. Melinda and Carrington. And may I present the next topic? The next topic is on the association of temperature and monthly variation in sudden out-of-hospital cardiac arrest of 196,000 cases. It's going to be presented by Dr. Nishimura from Japan.
Thank you for introduction. It is my great honor to present our study at this convention. Today, I'd like to talk to you about the seasonality of sudden cardiac death and the effect of low temperature. We have no conflict of interest. It has been claimed that coronary events and sudden cardiac death increase more in winters. However, the effect of temperature for OHCA is not clearly examined, because most of studies are based on hospital records in local area and have relatively small sample size. So the purpose of this study is to prove the seasonality of sudden cardiac death and its association to age and low temperature using large population-based study. We use the registry of sudden cardiac death from All Japan Stein Registry of the FDMMA. It is a nationwide population-based registry of sudden cardiac death based on the standardized Stein-style formats. It covers all 800 firefighting head offices and cover all over 47 prefectures. The study population is as follows. We included all patients over 18 years old and from 2005 to 2008. EM emergency service persons recorded the information of patient with the cooperation of a physician in charge of patients. We divided the patient into about 2,256 subgroups by region and the date of occurrence. Median 1.7 million people dwelled in each prefecture. We used Poisson regression to calculate the incidence ratio, and we collected the information of the mean lowest temperature from the Japan Meteorological Agency statistics. What you see here is the population characteristics of this study. We identified 196,000 cases in total. The mean age was 65 for men and 71 for women. About 93% were fatal cases. Let us see the trend of monthly change of cardiac arrest incidence. The peak was in January, and its nadir was in June or July every year. The risk of OHCA in January was 1.6 times greater than the risk in June. Interestingly, the trend was more marked for patients older than 65 years old, and the incidence rate ratio was 1.85, and for younger people, the incidence rate ratio was 1.23. By contrast, the trend was same for male and female. Next, the mean age was high in winter. This is partly explains the elderly was susceptible to cold stress, but it does not explain the seasonality totally. From this slide, you can see the seasonality remained after adjustment of age and sex. With this in our mind, we cite the association of mean lowest temperatures in local region and the risk of OHCA. From this figure, you can see we found the incidence ratio was inversely associated with mean lowest temperatures of local region. Every 1 degree decrease of temperature increased 1.3% of OHCA, and 10 degree change increased about 40% by Poisson regression. However, after adjustment of age and sex and low temperatures, still monthly trend existed. Here. Some mechanisms still remained uncovered. The strength of this study is that this is the first population-based study demonstrated the nationwide effect of temperature on sudden cardiac death. The climate diversity from cool temperate zone to subtropical zone in Japan clears the effect of temperature. The The weakness of this study is that the diagnosis for the cause of cardiac arrest was partly done by general physicians and emergency physicians, not always the cardiologists. And we have no information of prior risk factors in many fatal cases. The mechanism of seasonality is probably multidimensional. Low temperatures increased sympathetic tone and systolic and diastolic blood pressure, but some other biologic factors such as cholesterol and triglyceride and fibrinogen and activating factor 7 is also increased in winter. Some studies suggest influenza seasonal patterns of infection, such as influenza, is correspond to the pattern of increase of certain cardiac deaths. And some study also shows the stress for holidays is a cause of the certain cardiac deaths. In conclusion, occurrence of OSCA showed a monthly trend with its peak in winter months. The people older than 65 years old and the low temperature was a risk of OHCA. However, there was a residual monthly variation after adjustment for age and lowest temperature. The alert for cold season, especially for elder people, is of great value for the prevention of OHCA risk. Thank you for this opportunity.
Thank you very much. An excellent paper. This paper is open for any questions.
Well, excellent data, and it's really, really a fantastic study. Do you have, I appreciate that for the whole population you don't have all causes of death, but was there any subgroup or any area where you could get some information?
Actually, we have the same trend for all cause of death and the strokes, but it's too complicated to model for this, so we just analyze cardiac arrest only. Yeah.
Okay, if no more questions, thank you very much. Next paper is the clinical benefits of percutaneous coronary intervention in early latecomers with acute ST elevation myocardial infarction. It's going to be presented by Dr. Sim from Korea.
Good afternoon, ladies and gentlemen. I'd like to talk about clinical benefit of percutaneous coronary intervention in early latecomers with acute ST elevation myocardial infarction. Clinical benefit of PCI is controversial in stable patients with ST elevation myocardial infarction presenting between 12 and 72 hours after the symptom onset. Randomized clinical trials have shown conflicting results on this issue, and major guidelines do not recommend PCI for patients with ST elevation myocardial infarction presenting more than 12 to 24 hours unless they have persistent chest pain or hemodynamic instability. In this study, we evaluated the efficacy of PCI in early latecomers presenting 12 to 72 hours after symptom onset with acute ST elevation myocardial infarction compared with conservative medical treatment. The study population of this analysis were collected from the Korea Acute Myocardial Infarction Registry. The Korea Acute Myocardial Infarction Registry is the largest IMI registry which included 55 primary PCI centers in Korea. The Korea Acute Myocardial Infarction Registry was launched in November 2005, and it has now data on more than 45,000 patients with acute myocardial infarction. A total of 2,640 ST elevation myocardial infarction patients from the Korea Acute Myocardial Infarction Registry who presented 12 to 72 hours after symptom onset were analyzed. Patients with hemodynamic instability such as cardiac arrest, ventricular arrhythmia at presentation, advanced atrioventricular block, higher Killep class, low blood pressure, tachycardia, and those who underwent fibrinolysis were excluded. Out of 2,185 patients who underwent PCI, patients who underwent immediate PCI and urgent PCI during conservative treatment were also excluded, and the remaining 1,889 patients with PCI group were compared with 455 patients who received conservative medical therapy. Study endpoint was the composite of the MI rate at 12 months. Baseline clinical characteristics showed that patients in the PCI group were younger, more likely to be men and smokers, less likely to have a history of chronic kidney disease, myocardial infarction, angina pectoris, PCI, heart failure, stroke, and peripheral artery disease. Patients in the PCI group more often had chest pain at presentation, had lower heart rate and lower killer class, and lower incidence of left bundle branch block and higher incidence of anterior myocardial infarction. PCI group were more likely to have increased levels of lipids, lower level of creatinine, and higher level of troponin, and the distribution of anti-proBNP was different between the two groups. Among the 455 patients in the medical therapy group, 29% of the patients underwent diagnostic coronary angiography, and the distribution of infarct-related artery was not different between the groups. However, the rate of pre-PCI TIMI flow grade 1 or 0 was higher in PCI group, whereas pre-PCI TIMI flow 3 rate was higher in conservative management group. Patients in the PCI group are less likely to suffer cardiogenic shock, cardiopulmonary resuscitation, mechanical ventilation, acute stroke during hospitalization. And patients in the PCI group were more likely to receive adequate anti-ischemic management during hospitalization, such as antiplatelet therapy, beta-blocker therapy, ACE inhibitor or angiotensin receptor blockers, and diuretics and statins compared to conservative management group. Unadjusted clinical outcome analysis showed that PCI group had lower in-hospital mortality, lower adverse cardiac events at 30 days, 6 months, and 12 months compared to conservative treatment group. Since this study is a retrospective analysis, adjustment for potential confounders were performed by using propensity score stratification. Propensity score for the likelihood of receiving PCI was calculated by including 52 variables, and the propensity score was divided into quintiles to adjust for potential selection bias. And the degree to which propensity score balanced the measured covariates was assessed by measuring absolute standardized difference, and as is shown in this slide, standardized difference after adjustment of all variables were less than 0.25, indicating that all of the measured covariates were well balanced after adjustment. In each quintile of the propensity score, the treatment effect of PCI was greater than medical treatment group, and the pooled average treatment effect of PCI was significantly greater for PCI than conservative management group, indicating that patients with the same likelihood of being selected for PCI are more likely to benefit if they actually undergo PCI. And the propensity adjusted 12-month death MI-free survival was higher in patients receiving PCI than conservative medical management. And subgroup analysis for 12-month death MI rate showed that the treatment effect of PCI was consistent across all subgroups, including patients presenting without chest pain and regardless of the patency of the impact-related artery. And multivariate analysis for predictors of 12-month death MI rate after PCI showed that patients with older age, male gender, higher levels of hsCRP, anti-proBNP, complex lesions, and reduced post-PCI TIMI flow rate had worse clinical outcome. However, PCI performed within 90 minutes after arrival was not associated with improved clinical outcome. This study is limited in that it is an observational retrospective study, and some important measures of patient outcome were not collected or available for this analysis, such as amount and fluctuation of ST elevation and chest pain, and status of collateral circulation and myocardial viability. In conclusion, in stable patients with ST elevation myocardial infarction who presented 12 to 72 hours after symptom onset, PCI was associated with significant improvement in 12-month clinical outcome compared to conservative treatment. Additional studies are warranted to evaluate the efficacy and optimal timing of PCI in this patient population. Thank you for listening.
Thank you very much for this excellent paper from such a big data set. It's open for questions. Any questions?
Very good data. Two questions. Could your results, because it's an observational study and therefore it's not randomized, be due to the fact that we actually have two different populations? So there is let's say, a sample bias on the terms of comparing two different populations. And the second question, if I understood correctly, you didn't look at the treatment. For instance, the type of antiplatelet therapy these patients were taking. Was it the same? Was there any difference in terms of the treatment, the medical treatment that the two populations were taking?
Okay, thank you for the good question. As you mentioned, this is not a randomized trial, just observational study, and patients in the conservative management group were older and had more comorbidity and worse baseline characteristics. So even if we performed propensity adjustment, unmeasured selection bias cannot be controlled for. And about 29% of the patients in the conservative management group underwent diagnostic coronary angiography, but they did not receive PCI. And the reason why PCI was not performed was not clear from this registry, but probably due to older age and patient or family's refusal to undergo invasive strategy. And the next question was about medication during hospitalization. And as I presented, patients receiving PCI were more stable, even though we excluded patients with hemodynamic instability, and they received more adequate management with anti-ischemic medication. And we controlled for those differences in medical treatment during hospitalization using propensity score analysis, and those medications included in the analysis may have been controlled for.
But did you look specifically at the antiplatelet agents and anticoagulation that was done during the hospital?
Right. We included in the propensity adjustment model the use of unfractionated heparin and low molecular weight heparin, and the use of aspirin, clopidogrel, and xylitazole, which has been commonly administered in Korea.
Okay.
Just a quick question. Do you notice any variations in the regional variation, geographical variations from this study? Because it comes from so many different centers.
Right. In Korea, we included 55 primary PCI centers, and I think the collection of data from PCI centers across Korea, they represent the treatment strategy in Korea, and the treatment methods for acute myocardial infarction is not different from hospital to hospital. And in Korea, it is common practice to perform diagnostic coronary angiography after successful thrombolytic therapy or in patients without hemodynamic stability with ST elevation myocardial infarction. That is why I think we could get this kind of results.
Very good. Well, thank you very much, Dr. Sim. And now we move to the next presentation. It's coming from Taiwan. And Dr. Su will present the association between clinical symptomatic hypoglycemia with cardiovascular events in type 2 diabetes, a nested case control study in nationwide representative population. Dr. Su?
Oh, thank you. This one. Thanks. Mr. Chairman, ladies and gentlemen, I'm honored to be here and to present our result of our study about the association of clinical symptomatic hypoglycemia with cardiovascular events and the total deaths in type 2 diabetes. And this is a nationwide population-based study. Here is my disclosure. Hypoglycemia is frequently noted while treating diabetes patients. The incidence of mild hypoglycemia episode is around 2 to 10 per patient per year, and the severe episode is around 0.1 to 0.7 per patient per year. It is associated with reduced life quality, treatment satisfaction, reduced therapy adherence, and it is more commonly found at patients with HbA1c less than 7%. And it may be also associated with increased long-term morbidity and mortality. The cardiovascular complications due to severe hypoglycemia were well known before. Many mechanisms were supposed, such as increased risk of cardiac arrhythmia due to increased QT interval or sudden cardiac death. And some studies also suggest increased risk of ischemic heart disease due to sympathetic surge or destabilized atherosclerotic plaque or increased platelet aggregation. Previous many epidemiological and clinical trials which investigated the association of hypoglycemia and kidney outcomes during hospitalization of diabetes patients showed a rapid risk of hypoglycemic episode to clinical outcomes, including all-cause deaths and some CVD deaths. However, most of these study patients were admitted with acute coronary syndrome. This meta-analysis, including UKPDS proactive, advanced VADT, and ACCORD study, was published in Lancet in 2009. Although with increasing episodes of hypoglycemia in intensive treatment group of diabetic patients, the intensive blood sugar control does not necessarily increase the risk of coronary heart disease events. This data suggests that therapy in diabetic patients that increase the risk of hypoglycemia will generally not associate with increased risk of cardiovascular event, especially for coronary heart disease. Furthermore, recently, a post-hoc analysis from advanced study has also revealed that severe hypoglycemia is strongly associated with increased risk of adverse clinical outcome, including macrovascular, microvascular, CVD, and even total death. From previous evidence, the impact of clinical outpatient hypoglycemic episode in type 2 diabetes patients on long-term cardiovascular outcome remains unclear. Whether the hypoglycemic episodes are a risk factor or marker for future cardiovascular events remains debatable. So our objective is to investigate the association of outpatient and in-hospital hypoglycemic episodes with long-term outcomes, including cardiovascular events and all-cause mortality in treated type 2 diabetes patients. Second is to explore the temporal relationship between hypoglycemic episodes and the events. Here is our research design method. The study population identified from the 1 million patients in the nationally representative sample data set released by the Taiwan National Health Research Institute during 1998 and 2009. A total around 80,000 newly diagnosed diabetes patients were identified with more than 3 times of diabetes diagnosis by the ICD-9 code. We designed a prospective cohort consisting of hypoglycemic type 2 diabetes patients with randomly selected and age, sex, diabetes duration matched cases without hypoglycemia. The severe hypoglycemia was defined as diabetic patient with hypoglycemia identified from the hospital claim data set. On the other hand, the mild hypoglycemia was defined as diabetic patient with hypoglycemia identified from the outpatient claim data set. We investigated the relation of hypoglycemia to total mortality and the cardiovascular event including stroke, coronary heart disease, cardiovascular disease, and hospitalization from all causes. Here is our flowchart of study population. Total around 80,000 newly diagnosed diabetes patients were identified from the data set. 500 severe hypoglycemic patients and about 1,344 mild hypoglycemia cases with their matches were included and followed up the whole treatment course. This slide shows the clinical characteristic of the severe and mild hypoglycemic patient and their matches. Individuals who experienced hypoglycemic episode were more likely to have comorbidity conditions such as hypertension, liver disease, renal disease, previous stroke, or heart disease than those who did not experience a hypoglycemic episode. Furthermore, they also have higher percentage of mental disease, cancer history, and insulin and sulfonylurea medication uses. However, there is no difference between hypoglycemia group and the non-hypoglycemic group in socioeconomic status. In multivariate analysis, after adjusting for multiple covariates, the mild and the severe form of hypoglycemia all showed increased hazard ratio for stroke, coronary heart disease, cardiovascular disease, and even total death. We also do a propensity score match analysis. After propensity score match analysis including diabetes treatment and covariates, the hypoglycemia groups still have higher hazard ratio for CVD and any cause of hospitalization and all-cause mortality, with the hazard ratio around 2.0 to 2.5. This figure shows the survival curve of hypoglycemia and the hospitalization. The hospitalization survival curve divided significantly after the first year. More than 50% of patients had been admitted in the first year after the hypoglycemic episode. This trend was similar for different other clinical endpoints, including stroke, coronary heart disease, and cardiovascular disease, and even total mortality. So in conclusion, the hypoglycemia episode in outpatient clinical treated type 2 diabetes patients, both mild and severe form, are strongly associated with further major cardiovascular events, including stroke, coronary heart disease, and CVD, any cause of hospitalization, and even all-cause mortality. Diabetes patients who are vulnerable to hypoglycemia have more comorbidities, including hypertension, liver disease, renal disease, mental disease, cancer, and previous stroke or heart disease. Medications, including insulin and sulfonylurea, are also important factors that promote hypoglycemic episode. Once outpatient treated diabetes patients have hypoglycemic episode, cardiovascular and hospitalization events occur most frequently in the first year after the event, regardless of whether the hypoglycemia was mild or severe. We thanks to Taiwan Society of Cardiology, and here is the co-author. Thank you for your lesson.
Thank you very much, Dr. Su. This paper is open for discussion. Professor Cleveland.
It's a very nice analysis, and when you combine that with the overwhelming evidence that the diabeticians have done nothing to benefit patients through attacking blood glucose, is it not about time we took diabetes over as a cardiovascular society and pulled the diabeticians into some sort of order, because they seem to be doing more harm than good?
That's a political statement, John.
They seem to be doing more harm than good through their mismanagement of diabetes. And diabetes, the blood glucose is an epiphenomenon of diabetes, and it's not the disease.
Yeah, I totally agree with your comment. And from the study and the previous evidence, I still believe that the hypoglycemia may be a marker, not a truly risk factor. But in our study, you can see that there is temporary relationship. If you have hypoglycemia in your clinical treated diabetes patient, you must watch them, this kind of patient, because in the first year, there will more than 50% of patients will get any clinical event. And in our analysis, the most frequent admission cause of this patient is CVD. Also is a CVD. And I think this hypoglycemia is also truly a risk factor, but our study have not the evidence to show that, because we cannot provide maybe the dose response phenomenon, just temporal.
Do you think that you have the possibility of doing a study to replicate what others have shown, which is that less intensive control of blood sugar is a good thing for diabetics?
I don't think so. But we
why not?
I totally agree. But I think we should see the hypoglycemia is a marker.
Did you actually look at the type, or is there any difference in the type of anti-diabetic agents that were used?
Agents?
Well, the medication, the anti-diabetic medication.
Yeah, no, but there is no evidence from our study because we
did you look at that? Specifically the types of...
Maybe, I know what you want to say, but we just can identify the insulin or sulfonylurea medication used in our database, and such as DDP4 or any other diabetic patient case, their use is not so long, so the case number is small.
I see.
So we can further, maybe 2 or 3 years later, we can further analyze the other medications.
Okay, I understand. Okay, very good. Any other questions? Thank you very much. And we move to the next presentation coming from Indonesia? India, sorry. Dr. Garg, glycosylated hemoglobin A1C in non-diabetic patients, an independent predictor of coronary artery disease and its severity. So, Dr. Garg, please.
Thank you, Mr. Chairperson. Good afternoon, everybody. My research topic is glycosylated hemoglobin, that is HbA1c in non-diabetic patient, an independent predictor of coronary artery disease and its severity. Greetings from SGPJ, Lucknow, India. As we all know that glycosylated hemoglobin, that is HbA1c, is an indicator of average glycemia over the last 2 to 3 months. And we use this test to know about the glycemic control in diabetics. And it is also a very well-known fact that high HbA1c level in diabetics are associated with adverse cardiovascular outcome. Even in non-diabetic individuals, high HbA1c levels have been correlated with higher cardiovascular disease, high cardiovascular mortality, higher carotid IMT, and increased carotid atherosclerotic plaque prevalence. But we do not have much data correlating this HbA1c in non-diabetics with angiographically proven coronary artery disease. We have epidemiological data, we have data in the carotid, but we do not have much data with the angiographically proven coronary artery disease. So we wanted to explore in this area, particular area, so we conducted this study with these 2 following objectives: to correlate HbA1c in non-diabetics with the angiographically proven coronary artery disease, as well as to correlate it with the disease severity and complexity. This was an observational, single-center, cross-sectional study, and all the consecutive patients undergoing diagnostic coronary angiography over the last 1 year were included, and all the diabetics, either previously known diabetics or recently detected diabetics, they were all excluded. And all patients underwent detailed clinical history and examination, including CAD risk factor evaluation, and BMI was calculated. Blood samples were collected for hemogram and biochemical examination, and GFR was calculated according to the MDRD study equation. HbA1c measurement was done using BioRat system, and all patients underwent diagnostic coronary angiography, and significant CAD was defined as more than 50% diameter stenosis in any vessel more than 1.5 millimeter diameter. And disease severity and complexity was analyzed according to the syntax score and according to the number of vessels diseased. This was our study population. Total 1897 patients were screened and 756 patients were excluded either because of diabetes and 2 patients because of the hemoglobin A variant. And finally, we included 1141 non-diabetic patients, and out of which about 80% patients had coronary artery disease and 20% had either normal coronaries or insignificant CAD. Then we divided our study population into 4 interquartile based on their glycosylated hemoglobin concentration. The first group had this HbA1c level less than 5.5, second had 5.5 to 5.8, and third 5.8 to 6.1, and fourth more than 6.1. In the subsequent presentation, I will maintain this color code for these particular interquartile, blue for the lowest and red for the highest interquartile. And then these study groups were compared regarding their demographic profile, their risk factor profile, their clinical profile, their angiographic profile, their biochemical profile. And statistical analysis was done on the SPSS 16 statistical software, and student t-test, chi-square test, ANOVA, and linear regression analysis and Cochrane Armitage trend test, they were done as and where required. And finally, the logistic regression analysis was done to determine the predictor of CAD and to determine the association of this glycosylated hemoglobin with the severity and chances of having CAD. These were our results. As you can see that with increasing HbA1c levels, significantly higher percentage of patients were older and were overweight and were hypertensive. However, the sex ratio was not much different and smoking was not much different in the different groups. And as expected, the blood sugar levels were quite correlated with the HbA1c, fasting blood sugar, random blood sugar. With increasing HbA1c level, these levels were high, and fasting blood sugar more than 100 mg%, that is the impaired fasting blood glucose, that was also significantly high with increasing HbA1c level. It increased from 10% in the first group to near about 30% in the fourth interquartile group. Interestingly, lipid profile was not much different among the 4 groups except VLDL. But important point was that almost all patients were on lipid lowering medication at the time of enrollment in this study, because we are at the tertiary Apex Institute. This was the correlation with the RFT. Serum creatinine was not significantly different among the 4 groups. However, the measured GFR was significantly lower with increasing HbA1c levels. This was relationship with the coronary artery disease. 80% population had coronary artery disease, and significantly high percentage of patients had coronary artery disease with increasing HbA1c level. It was about 62.8% in the first interquartile and increased to near about 90% in the fourth interquartile. And this trend was linear and significant. Then we analyzed our data for correlating between the level of glycosylated hemoglobin and chances of having coronary artery disease. In the unadjusted total data, the chances of having coronary artery disease were 1.8-fold, 3.4-fold, and 5.2-fold in the second, third, and fourth group in reference to the first group. Then we adjusted our data according to the major cardiovascular risk factors. First, we adjusted for age and gender. After this adjustment, odds ratio was significantly high. With increasing HbA1c level, the odds ratio was significantly high. Then we adjusted for BMI. Even then, the odds ratio was significantly high. Then we adjusted for smoking, hypertension, and dyslipidemia. Even then, with increasing HbA1c level, these odds ratio were significantly high. And then we adjusted for fasting blood sugar more than 100 mg%, that is impaired fasting glucose. Even then, this the association was maintained. Then we adjusted our data for all these major cardiovascular risk factors. Even then, the risk was 1.8-fold, 3.5-fold, and 4.9-fold in the second group, third interquartile, and fourth interquartile group in reference to the first group. And these p-values were significant. And these were the results of the logistic regression analysis. On this analysis, age more than 60 years, male gender, smoking, and this BMI more than 23, high LDL and glycosylated hemoglobin, they emerged as independent risk factor for coronary artery disease. An interesting point to note in this slide is that fasting blood sugar more than 100 mg/% was not an independent predictor for coronary artery disease. So this data clearly shows that with increasing HbA1c level, you have a higher chance of CAD, and this glycosylated hemoglobin is an independent predictor of coronary artery disease. Now come to the second objective. The second objective of this study was to correlate HbA1c level with the angiographic complexity and the severity of coronary artery disease. And these were the results. With increasing HbA1c level, the percentage of patients having coronary artery disease was significantly more. Percentage of patients having triple vessel disease and left main coronary artery disease was significantly more. And mean number of vessels was significantly more. And it increased from 1.1 in the first interquartile to near about 2 in the fourth interquartile. So these parameters clearly shows that with increasing HbA1c level, you have a severe coronary artery disease. And we analyze the complexity of the coronary artery disease by analysis of the syntax score. As we all know that syntax score more than 22 reflects the complex coronary artery disease. 22 to 32 is the intermediate, and more than 32 is the higher quartile, and both these are the complex coronary artery disease. So we analyzed our data for this syntax score more than 22, and as you can see that with increasing HbA1c level, the syntax score more than 22 was significantly more, and there was a quite significant linear trend. And the mean syntax score also increased from 9.9 in the first group to near about 20 in the fourth group. So these two parameters clearly shows that with increasing HbA1c level, you have a more complex coronary artery disease. And these were the trend from the Cochrane Armitage trend test. And you can see these trends for the triple vessel disease, left main disease, as well as for the sync test more than 22 were linear and significant. So this data clearly shows that with increasing HbA1c level, you have a severe coronary artery disease and complex coronary artery disease. We also analyzed our data after excluding patients with normal coronaries and insignificant CAD. Even then, these P-trend values were maintained. Then finally, we analyzed our data to correlate HbA1c level with the chances of having high syntax score. As you can see that with increasing HbA1c level, the odds of having high syntax score was significantly high. So, to conclude, in the non-diabetic patients, high HbA1c levels are significantly associated with CAD, and this association is graded, continuous, and is independent of conventional major cardiovascular risk factor. And elevated HbA1c level is also strongly correlated with disease severity and high syntax score. HbA1c is a surrogate marker for chronic dysglycemia and can be utilized as an independent predictor of CAD and its severity even in non-diabetic patients. And the clinical implication of this study is that pre-diabetics and individuals with milder abnormality in glucose control, they should be identified and they should be advised for an aggressive coronary risk factor modification and management. Thank you.
Well, thank you very much for this very nice presentation. It's open for discussion, this paper. I have a couple of questions. It's very, very interesting data, but one question regards the definition of coronary disease. You use an anatomic definition with 50% of luminal narrowing, which we know has some limitations in terms of meaning. Did you actually have any sort of functional assessment or some more detailed assessment in terms of the type of coronary disease, either by invasive or non-invasive methods? So that's one question. And the second one is if you look at the confounding effect of any other drugs, like diuretics or any other drugs that may affect the blood sugar level of these patients. But very nice data.
Actually, all these patients were going for the angiography, so all these patients were evaluated for chest pain. We had data, extensive data, that most of these patients had evidence of inducible ischemia or typical chest pain, because this was the patient population going for the angiography. So because of the limitation of time, we have not presented this data, but most of our patients had either inducible ischemia or significant angina, so that's why they underwent. We take this definition of 50% because we are going for some analysis based on the syntax score, because the syntax score takes significant CAD as 50% diameter loss in any vessel more than 1.5 millimeter. So that's why we took a definition, because we have to take a definition for CAD.
Drugs?
Drugs, actually, we do not correlate it with in this study.
John?
Yeah, very nice data, and hemoglobin A1C is also a very good predictor of outcome in patients with heart failure who don't have diabetes. So, which is literature you should quote as well. One of the things that I think your data has convinced me of is that hemoglobin A1C is not a very good measure of chronic dysglycemia. Because 70% of your patients in your top quartile of hemoglobin A1C had a normal fasting plasma glucose. I think there's two processes going on here. One is glycosylation, and this is very, I know it's not strictly speaking, hemoglobin A1C isn't an advanced glycation end product, but it's close. It's in the same territory. That's something that happens with age, independent of blood glucose, and could perhaps be part of the aging process itself. So I just wonder whether there's two processes going on here. One is the sort of diabetes, but the other one is glycation and glycosylation, which may be totally independent from the glucose signal. What do you think?
Yeah, your point is very well taken. Yes, it is possible.
Yeah. You're not going to speculate further now. It's a very short answer to a very long question.
You gave the answer. So. Well, there's another question, please. Go ahead.
Congratulations. I'm from Georgia and I'm a professional diabetologist. A1C is very important for us. I know this diabetes is a national disease for India. Maybe we will call diabetes Indian diseases.
Yeah.
It's an interesting view which you introducing here. At any moment, my recommendation, maybe you measuring A1C several times, not one time. After 6 weeks, it will be the better result. Because this your view is a very original one. You know, the way call this condition pre-diabetes, and pre-diabetes very often they have coronary diseases. Of course, in Georgia also very often we have diabetes cases. It's a very important direction. Congratulations.
Thank you.
Thank you very much, Dr. Garg, and we move now to the last presentation. Contemporary impact of diabetes on 10-year survival in outpatients with chronic heart failure. Dr. Malcolm Arnold from London, Canada.
Thank you very much. It's a pleasure to have the opportunity to present some data. The data is basically founded around heart failure, but we were interested in the interaction between diabetes and heart failure. You'll notice that there's a number of co-investigators, and I acknowledge theirs and many other principal investigators in the different sites. And I'm speaking on behalf of all the nurses, physicians, and healthcare professionals in the Canadian Heart Failure Network. The disclosures are given, but the support that we receive from industry does not impact on the choice of the analyses that we do, and they are directed entirely by the CHFN Steering Committee. The Canadian Heart Failure Network, since inception, has linked a total of 29 academic and community centres of excellence who have multidisciplinary groups of physicians, nurses, and other healthcare professionals who are dedicated to advance the knowledge and treatment of heart failure. These specialised outpatient heart failure clinics across Canada share a common longitudinal electronic database to capture comorbidities, including diabetes, as well as medications, interventions, and other data. We can't define or we can't mandate exactly how many staff must be in any one heart failure clinic, but the minimum requirements are for a heart failure clinic of the CHFN to have at least one physician and one nurse who have specialized expertise in heart failure diagnosis and management. Each center themselves defines the specific services that they can offer based on Canadian and other guidelines. This shows us in the small hearts the distribution of the clinics across the country of Canada, which are placed in all of the major provinces in Canada. The focus of this presentation is the interaction, potential interaction between heart failure and diabetes. We all know that heart failure and diabetes are considered to be modern epidemics, and just some key recommendations from Canada and from Europe. For prevention of heart failure, we know that clinical assessment is recommended in all patients to identify known and potential risk factors for heart failure, as are listed in the brackets as a Class 1 and Level C. Also, all modifiable risk factors for heart failure, including those for coronary artery disease, hypertension, diabetes, and hyperlipidemia, should be treated in accordance to the current national guidelines. Those are only two, clearly, of tens of 30 to 40 recommendations. John McMurray, in the prevention of diabetes, notes that treatment with ARBs and possibly ACE inhibitors may prevent diabetes. Beta blockers are not contraindicated in diabetes and are as effective in improving outcome in diabetic patients as in non-diabetic patients, although different beta blockers may have different effects on glycemic indices. Thiazolidine diones cause sodium and water retention, an increased risk of heart failure and hospitalization, and should be avoided. And metformin is not recommended in patients with severe renal and hepatic impairment because of the risk of lactic acidosis, but is widely and apparently safely used in other patients. And that is just a snapshot of the two situations of diabetes and heart failure, and the things that some of the things that we should be aware of as we approach this. So we're looking at diabetes and heart failure, and the background to that is heart failure and diabetes, as we've implied, are common chronic cardiovascular complications which can compound each other. We wish to determine the impact of diabetes on the prognosis of ambulatory heart failure patients in this contemporary cohort of patients in the network. The CHFN network has 29 heart failure sites across Canada that we've already identified, and we have a longitudinal outpatient database over the last 10 years. And for this purpose, we are including a one-year minimum follow-up in the currently presented statistical model. Patients had to be over the age of 18, a minimum of 2 visits separated by a month in follow-up. Most had many more than that, and followed up for 11 years with 1 year minimum follow-up. Methodology, we wish to determine the mortality rate of diabetes in heart failure patients. For the purpose of this analysis, baseline data from the first heart failure clinic visit were analyzed and time to death was recorded. To be included in the survival analysis, each patient had to have at least 2 clinic visits and at least 1 year of follow-up. The analysis included all mortality data on patients up to 10 years of follow-up. Kaplan-Meier curves were generated and identify the survival of patients with and without diabetes in the CHFN database over that 10 years. This is a 12-year plot of patients as they were accumulated in the different heart failure clinics across the country. And you can see that at the time that at the end of 2010, there were about 18,800 roughly patients in the longitudinal database, and 1,500 patients are added to the database approximately per year. What do these patients look like? They have a mean LVEF of 31.9%. We do not restrict the assessment and enrollment of patients who have preserved ejection fraction. So this represents both systolic and so-called diastolic heart failure. 69% are male. The mean age is 67, and 45% had an ischemic etiology. There was a distribution of NYHA class, which would not surprise you. All these patients are generally referred to the heart failure clinics. About 13% at the time of being referred were class 1, 40% in class 2, 43% approximately in class 3, and about 4% were in NYHA class 4. How many years since onset? About 64% were aware and had a diagnosis of heart failure for a year or less. 30% were diagnosed within the previous 2 to 10 years, and about 6% were seen with a diagnosis that had been made 10 years previously. So the majority of about 90% were seen within 10 years, but 64% in the first year. Cardiovascular comorbidities, not including diabetes, which I'll come to specifically. In general, 0 to 1 cardiovascular comorbidity, there were about 34%. About 60% of the patients had 2 to 5 comorbidities, excluding diabetes, and 5% had more than 5 cardiovascular comorbidities, excluding diabetes. Diabetes itself, 91% of diabetes was identified at the patient's first CHFN visit. The graph on the left shows overall that 30.3% had diabetes and 69.7% did not. Those who had diabetes, you can see the distribution was predominantly 2/3 type 2 diabetes, 26, about a quarter of the population had type 2 and were on insulin, and a smaller number were 6% at type 1. What about the medications that they were on, depending on whether the patient had diabetes or no diabetes? The lightish blue is those with no diabetes, and the yellow represents diabetes. For ACE inhibitors, there was no differential prescription between those who had diabetes and those who did not. In ARBs, there was a slightly higher use of ARBs in diabetic patients, and also there was a slightly higher use of beta blockers in those who had diabetes. With regards to ACE inhibitors, there were no differential significance between how ACE inhibitors, and these were 3 of the most commonly used ACE inhibitors, they were not different between those with diabetes and those without diabetes. ARBs were more commonly used in patients with diabetes for each of those 3 specific ARBs, which were the most commonly used ARBs in our database. The total use of ARBs was around 10%. Again, I should remind you that we as a network did not tell the individual centres what to do other than to follow national guidelines. Some of the other medications of interest are that Lasix was used more frequently in diabetes. Spironolactone was used a little bit more, and digoxin was, but the differences are very small. And lipid-lowering medications on the right-hand side were higher in diabetes. Amlodipine was used more in diabetes. The numbers are small. Amiodarone was the only one that was used less. The other medications are the use of statins, atorvastatin, simvastatin, rosuvastatin. All were used more frequently in diabetes than in patients not having diabetes. So we come to, with that background of the nature of the patients, the medications that they received, we followed these patients until death or until 10 years. And these are raw numbers with survival on the left of 1 year, 2, 5, and 10 years. And those who had no diabetes, the 1 year survival was 91%, and the 10-year survival was 39%, with a median of 8.1 years. Type 1 and type 2 were not different in terms of their survival, but type 2 on insulin had a lower median survival at 4.5 years. Remembering that there was no specific uniform intervention, but this represents what was happening in the different clinics who had special expertise in heart failure and followed them longitudinally. This shows over a 10-year period those in blue who did not have diabetes and those in green who did have diabetes. You can see that there's a significant difference with those with diabetes doing worse than those without diabetes, which would not be a surprise. If we were to say, well, what was the chance of being alive? What was the 50% chance of being alive? And in those who had diabetes, there was a 50% chance that they could live 6 years. If there was no diabetes, the statistical chance was that they could live through 8.1 years, which is a 2.1 extension of life. This then breaks down in a little bit more detail the type of diabetes, type 1 being in green, type 2 being in red, and black being type 2 and being on insulin. No diabetes, again, is the top one in blue. You can see that type 1 and type 2 were not significantly different in the rate at which they died, but type 2 with insulin gave the worst prognosis. Such that, again, if you were looking at how many people if you're looking at 50% patients being alive with type 2 insulin, that would occur at 4.5 years. With type 1 and type 2, which were similar, it would be 6.4 years. And without diabetes, you would have a 50% chance of living for 8.1 years. So in conclusion, the presence of diabetes was associated with poorer outcomes in chronic heart failure patients compared to patients without diabetes during prolonged follow-up for up to 10 years. Type 1 and type 2 diabetes treated with standard interventions had reduced but similar survival outcomes with 75% 10-year mortality risk. And patients with type 2 insulin-dependent diabetes had the worst outcomes, with an early separation of the curves and an 80% 10-year mortality risk. So in conclusion, clearly this was not an interventional but more observational analysis. Heart failure and diabetes are considered, as we've said, as modern epidemics with poor outcomes. Clinical practice can be very varied, but the CHFN centres apply guideline practices in heart failure and share care of diabetes based on their expertise and comfort. Prolonged follow-up in this analysis, as I said, was up to 10 years. Kaplan-Meier curves show the survival of patients and with and without diabetes over that 10-year period. In particular, mortality was high in diabetes with insulin, and these results should continue, or I should say the results are observational and cannot prove mechanism. These results should continue to stimulate appropriately designed and sufficiently powered interventional studies to try to improve survival, and more active collaboration among specialist clinics and new targets for RCTs may improve the quality and longevity of life in patients who have both heart failure and diabetes, and may reduce the risk of related comorbid conditions. Thank you very much.
Well, thank you very much for your presentation. It's now open for discussion. I have a couple of questions. It's very interesting data. You mentioned here heart failure as one population. My question is, did you actually look at, for instance, ischemic versus non-ischemic heart failure, and also in terms of function, preserved ejection fraction versus impaired ejection fraction? Did you look at that?
Well, within this analysis that I presented, the answer is no, but we are looking at that because it's a very logical next step.
Very good. Any further questions? Oh, sorry, please.
So somebody's got to ask questions.
I did.
That was very, very good. We've got similar data, and I was just wondering whether you'd had the opportunity of looking at hemoglobin A1C in your population, and in particular in the non-diabetics, because that's where the hemoglobin A1C seems to have its prognostic power. Once you've developed heart failure and diabetes, hemoglobin A1C seems to be pretty useless as a prognostic marker. But I was wondering if you had...
Yeah, we do have some measurements of HbA1c. Again, we don't pay the centres to fill in the data. So it depends on the different centres. Some centres always add the HbA1c, other centres rarely do. At this point in time, I can't remember the percent or the exact number of HbA1c.
Well, they probably wouldn't have done it in the non-diabetics, so you probably only have it in the diabetics.
It might be interesting from your question before, but it probably wasn't at the top of the mind of the physicians and nurses who were entering the data.
But there is relatively little information on prognostic power of hemoglobin A1c in the heart failure diabetic, and it suggests that the cut points used in the non-heart failure population are inappropriate and may actually be detrimental to care. Which brings to my point, do you think that we would actually improve the outcome of these patients by withdrawing some of their diabetes care or adding more?
I guess,
it's a loaded question.
Well, yeah. I mean, we really don't know the answer, do we? And so if you're... if you're... I'm trying to think of the right adjective, but I can't actually come up with one. But if you're a radical, which is a little bit too strong, I think you would be very interested to pursue hemoglobin A1c in patients who don't have diabetes. And I think that radical is probably too strong.
I have to say it's a common practice of mine, especially in patients with more advanced heart failure and diabetes and renal dysfunction, really back off on the anti-diabetic therapy, because I think that that's actually contributing to the sodium retention and the difficulties that these patients are getting into.
That I would definitely agree with, and that may have other implications, but yes, we do the same.
Well, thank you very much. We finished on time. This was, as I've mentioned in the beginning, the first time we had these best abstracts from the affiliate societies. Thank you very much to all the speakers. Thank you to the audience. And thank you to my co-chairman, Dr. Sim. Thank you.